Next up, we have Joanna Chen, who's a MD PhD student at the MSTP program, doing her PhD in Biomedical Engineering. She's going to talk to us about enhancing prostate cancer diagnosis from medical imaging via image geometry-informed deep learning. Joanna.
Good morning. My name is Joanna Chen. I am a fifth-year MD PhD student, third year in the Biomedical Engineering program, and it is my pleasure today to present our work titled Enhancing Prostate Cancer Diagnosis from Medical Imaging via Image Geometry-Informed Deep Learning. So prostate cancer is one of the most prevalent cancer affecting male globally. And in the United States alone, approximately 11% of men would receive a prostate cancer diagnosis during the course of their lifetime. The susceptibility to developing prostate cancer rises with advancing age, demonstrating a higher incidence in particular ethnic groups, and is often linked to genetic mutations. Now, consequently, the screening practices have been implemented for the diagnosis of prostate cancer, guided by the individual's risk profile in order to facilitate early detection and inform the decision-making process. However, in the US, a staggering 77% of men are diagnosed with localized prostate cancer, which is often characterized as indolent and with a low likelihood of progressing to metastatic disease within a decade. Now, for individuals diagnosed with clinically significant prostate cancer, the 5-year relative survival rate is a mere 31%. However, the slow growth of indolent prostate cancer frequently results in most males dying from other mortality causes before the disease even reach a clinically advanced stage. Yet many of those indolent cases are subject to unnecessary burdens of biopsies and treatment, and thereby mitigating the risk of futile toxicity. Hence, a pivotal focus in prostate cancer management involves the identification and treatment of the aggressive, clinically significant prostate cancer that is prone to metastasize during the course of the patient's lifetime. Simultaneously, it is also critical to spare the individuals with indolent prostate cancer from the unnecessary burden of biopsies and treatment, and thus ensure a more effective and also personalized care strategy. In the current prostate cancer diagnostic workflow, the initial screening practice involving prostate-specific antigen test. In order to account for prostate size, PSA is often divided by prostate volume estimated from imaging to form a PSA density value. The current diagnostic standard for prostate cancer involving imaging-guided needle biopsy. Pathologists would interpret the biopsy tissue to form a Gleason grade score, which assesses the cancer's aggressiveness and imply the likelihood of metastasis. A clinically significant prostate cancer is often defined as with a Gleason grade score larger than or equal to 2. However, biopsies are susceptible to sampling error as it only collects a mere 0.45% of the prostate tissue, thereby may omit cancer heterogeneity and also missing on the tumor localization information. Apart from that, 50% of the biopsy tumor ended up being deemed indolent. In addition to the diagnostic limitations, it is inevitably an invasive procedure and carrying the risk of infection, bleeding, and in some cases even sepsis and hospitalization. And the risk of severe complications and the psychological burden that comes with it escalates with repeated procedures. On the other hand, multiparametric MRI is evolving its way into the current diagnosis of prostate cancer. The inherent advantage of multiparametric MRI is that it is a non-invasive procedure that not only captures entire prostate, but also is able to capture the surrounding anatomical area. Multiparametric MRI in prostate involves T2-weighted imaging, dynamic intravenous contrast enhanced imaging, diffusion-weighted imaging that features an apparent diffusion coefficient map, or often abbreviated as an ADC image. Currently in the prostate cancer diagnostic process, the multiparametric MRI serves two main functions. One is to estimate the prostate volume and assist in the PSA density calculation. And the other is lesion scoring via prostate imaging reporting data system, often abbreviated as PIRADS rating. Fundamentally basing mainly on T2-weighted and ADC images, PIRADS rating is critical in the evaluation and characterization of prostate MRI, based on whether or not the image might indicate if the tissue could be cancerous, and is functioning on a 5-point scale demonstrated here. Now, despite the potential of multiparametric MRI, its full utility is hindered by the time-consuming manual reading process and inter-rater variability. This AI model holds great potential to help maximize the diagnostic potential of multiparametric MRI via improved efficiency and effectiveness of image interpretation. And thus will be able to help prevent overdiagnosis and overtreatment, such as unnecessary biopsies. While efforts have been made to leverage AI models for enhanced diagnostic capacities in prostate MRI, variations in diverse scanning equipment, such as differences in MRI models, MRI vendors, and associated differences in MRI image voxel size, and also differences in MRI image orientation. All these factors pose obstacles and may impact model performance. Sensitivity to such domain shifts are often unconsidered in AI studies. However, we know that in the MRI image DICOM header, it actually contains crucial geometric information encompassing the image orientation and voxel size details. Therefore, the primary aim of this preliminary study is to strategically extract and integrate image geometry information into the AI model, with regard to enhance AI model robustness, adapting to diverse scanner sources. The MRI image geometry is often available from the image DICOM header as a 4x4 matrix. The image orientation and voxel size information is color-coded respectively. This matrix can be obtained from each MRI image and then flattened out into a vector of 9 values. Now, of note, the 3 translation components are ignored due to the translation invariant nature that is inherent to deep convolutional neural network. A residual convolutional neural network is used to predict whether or not a patient has significant prostate cancer from their MRI image. In order to incorporate the image geometry information, the aforementioned matrix extracted from image, flattened out, and then a multi-layer perceptron is used to fan out the image geometry vector into a vector that is of the same size as the number of feature channels, and then multiplied with the features in order to individually control the targeted channel. For feasibility analysis, we use a publicly available prostate X dataset, which encompasses 270 patients, and each patient has data available on age, PSA value, PSA density value, gland volume, and Gleason grade score. Each patient also comes with a pair of T2 weighted and ADC images. 80% of data, or 209 patients, were reserved for training, and 20%, or 61 patients, for testing. Now, before diving into the MRI-based model, we first take a look at the utility of the patient characteristics. Logistic regression models were applied to the 4 available clinical features. Discriminatory on significant prostate cancer was measured using the area under the receiver operating characteristic curve, or AUC, which is 0.78 for PSA density, as compared to 0.72 for gland volume, 0.68 for just the PSA value, and 0.62 with patient's age. We then apply the baseline ResNet that is without infused image geometry information to the T2 weighted and ADC images of patients. AUCs were 0.77 and 0.76 respectively, which is comparable to that of PSA density. We then further compare the modified ResNet transformed with image geometry information and show that it outperforms the baseline ResNet in prostate cancer prediction tasks for both imaging modalities, with AUCs of 0.82 and 0.84 respectively. To further assess the potential synergy of important clinical biomarkers and our derived imaging biomarkers, we combine the modified ResNet models, which are infused with image geometry information, with the logistic regression model on PSA density into an ensemble via averaging prediction probabilities, and observe additional performance improvement with an AUC of 0.89 in differentiating significant prostate cancer. So in summary, the study highlights the potential of infusing image geometry information into AI model, which improves discriminatory ability of clinically significant prostate cancer, compared to the modified ResNet with image geometry information to the baseline ResNet, emphasizing its potential efficacy in addressing these variations in scanners, such as orientation and voxel size. The model ensemble via averaging prediction probabilities trained on PSA density T2-weighted, and ADC images underscore the vital role of combining important clinical and imaging biomarker for more comprehensive analyses. In the future, we hope to conduct multi-site validation on this presented approach and further assess this approach with stratification on scanner variations and imaging protocol differences. I would like to thank everyone from the Onofre Lab, especially Dr. Onofre himself for the invaluable guidance on this work, Dr. Spranko, Aurora, Stape, Papadimitrios, Justice, Ventakaraman for the knowledge and expertise, the Yale MD PhD program for the constant support, and finally, the bid section, especially Dr. Taylor and the symposium organizing team for this wonderful opportunity. Thank you so much for your attention and time.
That was excellent. Thanks so much, Joanna. And I mean, a big round of applause for, 3 trainees, starting off the session for the first AI symposium. And I just want to make sure that, the next presenter is actually a faculty member. So I want a big round of applause for the trainees who gave exceptional talks. Thank you. I think next up, we have a question from the audience. So we're going to start with the audience questions first. Please introduce yourself.
Hi, I'm Larry Vitellano from the Child Study Center. I wanted to thank you, Dr. Chen, for that really interesting and clear presentation. I think some of the older people in the audience have a special interest here in your work. Thank you for doing it. But all kidding aside, I was wondering your thoughts about, so much data comes when you generate this from AI and the capacity to just really go through so much. Do you think there's any opportunity through AI to provide clearer explanations of these analyses to patients? It's really confusing for many of our patients about how to integrate test results and recommendations. And so is there a way that AI could also provide lab results and tests analyses in a way that's understandable to patients with the best protocols recommended without ignoring the kind of risks and controversies of any treatment we recommend? What's your thoughts about using it for clinical patient advantages? Thank you.
Yeah, thank you so much. First of all, I'm Dr. To be, hopefully one day, so I'm very flattered. But it's a very broad question. I'm not sure if I qualify to answer it in full details, but I think it's certainly some things that people are working on. I think a lot of large language models are focusing on, sort of transitioning the clinical jargons, as we were taught in medical school, into the more explainable information to patients. Specifically in the image processing field, I think the image itself, really speaks a lot in terms of how we're able to, for instance, as Eleanor pointed out, using GrandCam or other, explainable features to highlight the portion that's relevant to patient that helps explaining this process to patient. And I think it's definitely like a very good, research direction and interest, to be able to not only just improve things in numbers and the AUCs, which means a lot probably to our urologist faculties, but they also need to convey it, to patients. And I think there are works to be done and probably a multimodality model, as we'll probably present in the poster section actually later on by our lab, to integrate more details and, inform the patient in a more, I would say, explainable and also a plain way to let them know the clinical importance in some of the work.
Perfect. Well, thank you. Thanks for the question. I'm going to ask one question. I'm going to walk over and then look at the Zoom next. So, you mentioned there was the creative part about your work was looking at geometry as an element that improves performance and generalizability of your tool. And then you combine that information with the current existing risk scores. What additional pieces of information do you think you can incorporate in this to make it even better?
Yeah, actually, we had a great discussion with our MRI experts yesterday. There are parameters, physics parameters of MRI that we may consider to add into it in addition to the current image geometry information. And additionally, I'm going to shamelessly advertise for the posters that we're going to have, but we can also infuse other clinical biomarkers, into the model itself and see if, early conditioning on the feature instead of later combining those biomarkers may shine more light in terms of where are we going to focus on the image and how it might actually improve the prediction ability of the models.
Awesome. Thank you. I'm going to look real quick at the Zoom. If there are none, then we'll keep moving. Okay. I'm guessing it's Dr. Rosenthal. So his question, Dr. Rosenthal is a general medicine doctor at the VA. He leads the CBIT, the Innovation Center at Yale. Could you use the VA data in any way, shape, or form? And how would you sort of go about incorporating the VA, which is a large population of older men that have prostate cancer as a key consideration?
It's a great question. Actually, if you saw my acknowledgement slide, we actually have Dr. Amy Justice from the VA who's collaborating with us and hopefully putting out a grant that, as we know, like VA has this very rich database that even dated back years. That information, probably provide a lot of different directions in varying different scanner models that may shine light on this work.
Awesome, thank you.